Good morning, guys. It is December the 8th, 2020. Last exam has been taken, RT210A, which was hyperinflation, restrictive and obstructive lung diseases, where today is a makeup lab day and I started my review. Don't forget, on Thursday, we'll be online only from home, and I'll just be continuing to review. Speaking with Mr. Curbo yesterday, he decided we are going to do orals on campus. So when you take the day for your oral, you'll be here on campus. We'll come on to the classroom. We'll be doing some review and practice for the final. And they'll come get students one at a time or two at a time to go over to the lab and do your oral. Okay? So that's how that's going to roll today. So like I said, we'll start doing a few courses. I'm going to do RT210A and B, and may do a little bit of oral review with the cards. And then we'll do some checking off if anybody needs to check off in the lab, okay, for makeup. All right. I am recording the session. Again, I won't be recording the oral questions. So if you're not live or you're not here, then you missed that. Okay. All right. We're getting ready to get started with RT210A. Was talking about terminology, measurement terminology, and the ethics. Just remember your metric volumes. We didn't do a lot of with deci and milli too much, but as far as having to know what they are. But this is the notations here. DL was a deciliter, a deciliter, centiliter, and milliliter, right? Main thing is we deal with a lot of milliliters when we're talking about volumes, as far as volume of liquid or as far as volume of air or gas. Don't forget that cc's and milliliters are the same thing. Okay, cc's and milliliters are the same thing. We talked about the kilo as what you do, but we didn't do kiloliter, we did kilograms, right? Kilogram. This is just kind of showing you some metric volumes that we went over. Let me see what was important. This is a nice little chart here to kind of show you which way you're going. 1 meter, liter, or 1 gram, right? It's right here at the 1, okay? And then let me see if I can. Oh, okay. All right, so deci will be going this way. Centi, right? Milli, micro, nano, right? Way over, okay? Nano is very, very small. All right, then if you go from this way, deca will be 10, hecto will be 100, and kilo is 1,000, okay? So they're just kind of showing you where your decimal goes with the terminology. One of the conversions was, you might see this one, we talk about the 2 pressure measurements in centimeters of water and millimeters of mercury. Those are 2 pressure measurements. If they ask you, how much is 1 centimeter of water? Well, this is it, 0.74 millimeters of mercury, okay? 1 centimeter of water is equal to 0.74 millimeters of mercury. And 1 millimeter of mercury is equal to 1.36 centimeters of water, okay? So they may, when you take your final or when you're going into your board exams and stuff, they may ask you how much is 1 centimeter of water, just so you can relate to the both, okay? These are the both pressure measurements we use, and this is how much they are if they want to get into detail, okay? Other conversions will be your linear. We deal with inches and we deal with centimeters, right? Inches and centimeters when we're talking about the length of the trachea or how long something else is, right? How far the diaphragm excursion is, little things like that. It could be either in inches or centimeters. You need to know how to convert those, okay? 1 inch is 2.54 centimeters. Gallons is 1 gallon is 3.8 liters. We usually don't use gallons when we're dealing with respiratory. All right, but kilograms, 1 kilogram is 2.2 pounds. Okay, you'll have to multiply by 2.2 to get the pounds. If you go backwards, you divide by 2.2. All right, so make sure you understand those. Other conversions, temperature. Fahrenheit, 9/5 times Celsius plus 32. Celsius was 5/9 times Fahrenheit minus 32. Make sure you do what's in parentheses first. And Kelvin is what we measure all gases in, and that's Celsius plus 273. All right, this is just kind of a little transverse plane, frontal plane of the body, right? You have your laterals on your sides. Transverse plane is like right straight through the middle, right? Sagittal is going this way, frontal is going that way. It's just, you don't have to memorize these, but this is a good way of understanding where things are in the body as far as terminology is concerned. They may talk about lateral, they may say medial, right? Medial is more toward the middle of the body. Posterior, of course, is in the back, right? Anterior is in the front. Those terms, posterior, also known as dorsal, right? Anterior, also known as ventral, right? We talked about that. Proximal is up this way, like toward the torso up in here, and distal is away from the body, okay? If I stick my arms out, my fingertips will be distal to my body. It's away from the body, okay? Superior, of course, at the top, inferior at the bottom. Just some nice little terminology for you to see. Sagittal is going straight down the middle this way, cutting straight down, dividing the head left and right, yeah. All right, some terminology like what is a cold blue? Make sure you know what cold blue is. What is the co-arc, right? What was the co-arc? What is something that the medical director is responsible for in an RT department? What does AARC stand for? What does MBRC stand for? See, some of these are your oral questions that we went over. Triage the following. Make sure you understand how to determine who needs and how much oxygen therapy, emergency room treatment. Don't forget, this is kind of like that priorities list. Remember, there was a priorities list in this exam. It said if you got a page and you got all of these calls at the same time, which ones will you go to first? You need to make sure you remember which one of these you go to first, and all the way down to the last. True or false? Oxygen is flammable. Is that true or false?
False.
False. It supports combustion. Be able to name diagnostic service and respiratory care. What does CRT mean? Describe the therapeutic goals of oxygen therapy. You gotta know why do we give oxygen? Those 3 reasons we give oxygen, right? Sign this test, and you should don't worry about that part. Mini clinics. They got a couple of mini clinics. So for instance, 73-year-old male with chronic obstructive lung disease, COPD, is admitted to the emergency department with shortness of breath, which is not relieved with rest. So he's short of breath and he goes sit down somewhere and he's still short of breath. The patient has been admitted over 8 times during the past year for various respiratory problems. The attending physician feels that this episode may reflect the exacerbation of his COPD and orders for the respiratory care practitioner to administer inhaled MDI, right, meter dose inhaler device bronchodilator, okay? So he wants to give a bronchodilator MDI using a meter dose, okay. When the RCP, which is you, enters the room and begins to introduce himself or herself, the patient becomes quite defensive, stating that he doesn't require any assistance with respiratory treatments and that he should just leave the medication in the room. Respiratory therapist has not treated the patient in the past and has to decide how to respond. So remember what we do. When they refuse treatment, you explain the rationality of the treatment, and then you chart it. You never leave medicine in the room. Okay? Never say, okay, well, here you go. You don't leave medicine in the room. All right? There's some of the objectives. We know their objectives. That was that one. Wasn't much to 210A, right? Wasn't much to 210A as far as information is concerned. There was some terminology and little stuff like that. You need to make sure you go back into your notes and study that. Other than that, wasn't much to it. Intro to RT. See if this thing got anything different. Yeah. Same thing. Okay. All right. check something else right quick. All right. All right, a few other things. We had some, went to prefixes. We did the linear stuff. Temperature stuff. All right, those are all part of your lessons. Don't forget some of your root words, combining forms, right? Gastra or gastric, hardy, derm, pneuma, pleura, trachea, abdominal, adeno, hemo, right? Or hema, costo, cyto, vaso, bio, thorax, broncho, myo, myco. Don't forget the difference between myo and myco. And cyano, febrile and anaerobic. Don't forget what those terminologies are. You will see those on your finals. Okay? You got to know what's what. Gastro, you got to know that stomach. You got to know what hemo means, blood, right? Myco is fungus and myo is muscle. Don't make that mistake. A lot of people make those little careless mistakes that miss one. The final is 100 questions and it's 1 point apiece. All right, 1 point apiece. Prefixes, a and an mean negative, right? Apnea is no breathing. Anaerobic means without what?
Oxygen.
Without oxygen, good. Okay. Ab means away. Dive to, X, out of, right? Intra is inside. I mean, we talk about those three types of fluid. Intravascular or intracellular is fluid inside the cell or the vessel. Infra is beneath, like infrared. Those are colors beneath the color prism that you can't see. Inter is in between, like interstitial. Don't forget that. That's in between the cells. Macro, mal, mega, those type of words. Neo, right, is for small or new, right? Micro is small, neo is new, like neonatal babies. Ortho is to correct. So a bone doctor who corrects bone problems is an orthologist, or I forgot what they call it. Orthopedic, yeah. Sub will be below as well. Trans, through, contra is against. Hyper, hypo, tachy, and Brady. Of course, those are some you see all the time. All right, some of the suffixes, algia is pain, ectomy means removal. Gen is an agent. Oma is some type of tumor. Penia is lack of, like apnea is lack of breathing. Ostomy is the opening. And otomy is the cutting. Don't forget that. Or tracheostomy is the hole in the throat. And the tracheotomy is me cutting to make the hole. Okay? People miss that. That could be 2 points right there that you miss. Right? Itis, inflammation. Itis is inflammation. Ology is a study. Gram is a tracing. Like when we do gram stains, when we say gram negative rods or gram positive rods, or bacteria, when we do the bronchoscopy, we take some of the stuff out the lungs. Don't forget, we go gram trace it, right, to see what it is. Is it gram positive or gram negative, right? Some of the gram negative stuff is like Pseudomonas and Acetobacter and those type of things. We treat with what? What medicine do we treat with that? What medicine do we treat for gram negative rods? Like Pseudomonas, Acetobacter, things like that in the sputum. What would we give them? What's the name of the medicine that we give?
Is it the antibiotics, tobramycin and?
Anybody?
Is it the antibiotic?
Ms. Woods? Gentamicin and tobramycin. Those are the medicines we give for that, right? You got to know that. All right. Then, of course, that's when you put the stuff together. Directional terms. Make sure you go over your directional terms as well. Okay. Abbreviations. Big A, don't forget, is alveolar. Little a is arterial. Okay. P for pressure or partial pressure. So P little AO2 is the partial pressure of arterial oxygen. P big AO2 is the partial pressure of alveolar oxygen. All right. ATPD is ambient temperature pressure dry. And ATPS is ambient temperature pressure saturated. And same thing with the body temperature. ERV is your expiratory reserve volume, right? So all of these suffixes or these abbreviations, make sure you come and go back and study those. You can go back and look at this film and pause it, okay? Make sure you know that when you study with yourself or somebody asks you, make sure you know these by heart, because these are the ones that trip you up, that you forgot about, and you mess around and miss those and get less points. 1 point apiece on the exam, okay? All right, of course, make sure you know we talked about ethics and legalities. There's just a few things to remember about ethics, right? Make sure you look for some of the things like slander and libel, right? Those type of things that you might end up coming across in the hospital, like slander or battery, right? The different types of law. You have private law and you have a tort, right? We talk about the torts only in the in respiratory. We talked about the intentional things or the negligent torts. Okay, intentional will be battery, touching somebody without their consent. Libel, false writing about somebody, right? And slander is talking defamation about somebody. Okay, then negligence is not doing what you're supposed to do. Something happens to somebody because of a lack of your response. Okay, negligence, reckless disregard for safety of another. Malfeasance is execution of an unlawful or improper act. If you know you're not supposed to be giving that patient any kind of medicine, if you're not the nurse, you don't give pain medicine. If the nurse is not a respiratory therapist, she shouldn't be giving any respiratory medicine. Even though you think you know the patient needs it, that will be malfeasance. You can get in trouble for that, okay? Make sure you understand your patient's rights. Autonomy. What does autonomy mean? What does autonomy mean? When a patient has autonomy, what does that mean? They have a right to choose who they want. A doctor, the nurse, the respiratory, if they don't want you in their room, they got a right for that. They have a right to be a part of their own treatment, okay? To know what's going on. How do I want to do this? Do I want to do this or do I not want to do this? You got a right to know what are you doing to me? What is it going to do? How much does it cost? All those kind of things, what you don't hear a lot, but the patient does have a right to ask you that, okay? Veracity, make sure you tell the truth. It binds you to telling the truth. Then some other terminology here. Make sure you go back and make sure you understand these terminologies, okay? Also about the charting, how we use the SOAP format, right? Subjective, objective, assessment, plan. Subjective or information just you get from the patient when they say, I can't breathe, my stomach hurt, little stuff like that. Those are subjective, right? Information, what they're telling you or family members telling you about them. And then objective is stuff you get back from your results, right? You got blood, you got an ABG, you got things like that, and you found out some things yourself, some results. Those will be objective findings, okay? So if you had a question, say, what are the findings called from looking at the results of an ABG? What kind of findings would those be? Would that be objective, subjective, assessment, or planning? You got to be able to say, oh, that's objective, okay? Assessment is how we're going to deal with it. I'm looking at all of got what you said. I went and got some tests and see what's really going on, and then how am I going to put it together, okay? This is what I'm going to say. This is the diagnosis. This is what I think is going on, right? And then when I do my plan is how I'm going to tackle that problem. Okay. All right. Of course, you got the components of the chart. That's not really hard. Where to find different things in the chart. Make sure you understand this stuff. Remember, you can't study for the final in 3 days. This got to be something that you have been continuously doing, going back and answering these questions. Okay. And studying these notes. All right. So that's pretty much, that's RT210A review. Okay. RT210A review. All right, let's go into B, which was cardiac anatomy. Cardiac A and P. Find my, hold on, just use this one. I think this one might be. Oh, might be. All right. Slideshow for cardiac TV. All right, we got those objectives. Make sure you understand and how to be able to describe the contents of the blood, like the proteins, energy molecule, and your electrolytes. You got to remember all of the electrolytes and their value. Make sure you know the unit of measure, milli equivalents per liter. If you don't say that during the orals, you're going to get it wrong. Okay. Be able to tell me what a erythrocyte is, a leukocyte. There go those three positions of fluid there: intravascular, interstitial, and intercellular. All right. Make sure you're going to know, be able to perform these things as far as knowing the purpose of the blood. Remember, the blood had several purposes, the reasons for the blood. Make sure you be able to tell me those. Describe the location of the heart as you know, in those terms. Is it medial? Is it lateral to your body? Where is it? All right. Discuss the blood flow through the heart using the vessels, valves, and chambers. So that's remembering the blood flow through the heart. Make sure you're able to know that by heart. At home, you need to be able to tell me, okay, it starts with the superior and inferior vena cava and goes into all those different places and then to the body. Make sure you are able to do that. Okay, is everybody able to do that? All right. Okay. Oh. All right. Make sure you don't know the types of blood vessels. Only two types of blood, well, three types, but you have veins, you have arteries, and capillaries. Okay? Veins carry blood where?
To the heart.
To the heart, and arteries carry blood away from the heart, and the capillaries are in between those. In between, like fingers. Okay? In between. Understanding the blood pressure. Then you need to make sure you understand the pathway of electricity through the heart. Electrical conduction starts with the AV node and ends up with starts with the SA node and ends up with the Purkinje fibers. You need to know all the steps in between.
So I'm just going to ask you, because it's 6 steps on our note-taking guide. So, but it does end with the Purkinje fibers.
Yeah. Okay. Starts with the S. I don't know how many it is, but you need to know the steps.
No, it's something under there. But I watched the video just recently, and he kept on stopping with the Purkinje fibers. I'm like,
there's nothing after that unless it's something you read or something. You need to know from SA node to Purkinje fibers.
Okay.
Yes. All right. Then what happens during systole and diastole, right? Systole is what? Contraction or depolarization. Remember, don't forget those AKA terms. You need to make sure you brush up on those. Systole, AKA depolarization, AKA squeeze, AKA QRS, right? All of that's the same stuff going on, all right? And then diastole is AKA relaxation, AKA repolarization, and the bottom number of the blood pressure, right? Systole is the top number. So all those things you need to know. What?
You said QRS.
The QRS of the EKG. That's the
Yeah,
that's the
wave.
contraction.
Yeah, okay. I don't know.
All right. All right, make sure you understand the EKG waves. Those EKG waves, what they are. P wave, atrial, depolarization. Then the next thing is the QRS, which is the systole, or the what's going on. Contraction of the ventricles. The ventricles, okay? And then the T wave is the, Miss Woods? No. Repolarization of the ventricles. Repolarization of the ventricles. The atrials do repolarize, but you can't see it because of the QRS, okay? That would have been the U, okay? That would have been the U wave. There's a U wave, but you can't see it. Okay, PQRSTU, right? But you wouldn't see, you can't see it because of the QRS. So be it. All right. Of course, describing hypertension, shunting, knowing what cor pulmonale. What does cor pulmonale mean? Cor pulmonale. Hold on. Miss Rose, I don't know if you can, if you saying anything. Let me, my speaker is not plugged up. Hold on, Miss Rose, if you've been talking. All right, Miss Rose, you with me? Miss Rose? I can't hear you if you're talking. I don't hear you. I don't hear you if you're talking, Miss Rose. Okay. All right. So what is cor pulmonale? What is that? Okay, we'll write that down. You need to find that out. Congestive heart failure. What is that? It's CHF. What is it? Problem where? Where is that problem at? Left side. Left side heart failure, right? MI. What is MI?
Can you hear me?
Yeah, I hear you now.
Okay.
Okay. MI. What is an MI? What does that stand for?
Myocardial infarction.
Good. Yes. Myocardial infarction. What about ischemia?
No blood. Low blood flow.
No blood flow. Good. And shock is when you go into shock. When you don't have that blood flow, your body goes into shock. Okay? Massive blood loss, stuff like that causes the body to go in shock. Myocardial infarction. It's a heart attack. All right, Miss Rose, are you able to let them know what cor pulmonale is? Nobody here remembers.
It has something to do with the right ventricle.
Right-sided heart failure. That's what cor pulmonale is. Right side heart failure. And what patients, what type of patients have cor pulmonale? Pulmonary patients. Pulmonary patients, because the right side of the heart is the pulmonary circulation. So your COPDers and any other kind of pulmonary problem have cor pulmonale. It's when that right ventricles are not pumping like they should. Okay. Left side is the systemic side. Yes, the part to the body. So the left side will deal with your blood pressure and stuff like that. All right. Plasma. Don't forget what the plasma is made up of. 90% water, 10% solutes, which are protein, energy molecules, and electrolytes. All right. Elements like the erythrocytes, which are the red blood cells. They're made in the bone marrow, right? They contain hemoglobin, and hemoglobin carries, what is the oxygen. So if you don't have good bone marrow or you don't have good red blood cells, you're not going to have a good oxygen saturation because the hemoglobin is in the red blood cell. So if your blood is low, then you're going to have a low sat because you have a low hemoglobin, right? It's kind of like a chain link fence, right? Then leukocytes are the white blood cells, which are the soldiers of the body, containing the eosinophils, basophils, and neutrophils, right? When we have asthma problems, a lot of times there are allergic reactions, right? Remember we talked about asthma being allergic or non-allergic? So which one of these would I check to see if it's an allergic situation? Which one of these leukocytes? Eosinophils, because those are the ones that respond to allergic reactions. Okay, so if my eosinophil number is really high, then there's an allergy response going on in the body, right? That lets me know that. What about the basophils? What would I check or be warned about with the basophils? What does that do to the body or the blood?
Check for infections.
No. Basophils. Why would I be concerned about the basophils? What do they produce? The basophils produce heparin. Heparin. And heparin does what? Thins the blood out. Thins the blood out. So if I'm seeing somebody with a massive bruising, they're probably going to check their basophil count, see if it's up, right? They may be too much heparin in the blood. And of course, your platelets, which are responsible for your clotting, right? You get cut, the platelets go and try to build up a wall to keep you from bleeding. Those are the electrolytes here, okay? Don't forget you have that list with your normal values on it, bless you. That you can go by that one. Either one will be fine. They're all the same. It just may be off by 1 or 2 digits, okay? But sodium, 135 to 145 milliequivalents per liter. Chloride, 96 to 105 milliequivalents per liter. Bicarb, 22 to 26 milliequivalents per liter. Sometimes you see millimeters per liter, something like mmol. Some machines for bicarb would say mmol. Same thing. Okay. Potassium, 3.5 to 5 milliequivalents per liter. Calcium, 4.25 to 5.25 milliequivalents per liter. Remember we said calcium is like buying a gallon of milk. You get milk, calcium from milk, right? And so milk costs about $4.25 to $5.25, right? $4.25 to $5.25 for a gallon. So I remember that. And then potassium, you get potassium from your bananas. And bananas come in about 3.5 to 5 of them in a bunch. You get about 3.5 to 5 in a bunch of bananas when you pick up the bananas. So that might help you remember. Magnesium, 1.4 to 2.2. I think it's 1.5 to 2.5 on the sheet. Something like that, same thing. Magnesium, very, very important electrolytes. Now, out of these electrolytes, which one of these 2 electrolytes are responsible for depolarization and repolarization? Sodium and potassium. Everybody understand that? Remember that? Okay. So the intracellular, which one is there? Potassium. Extracellular is what? Sodium. And the sodium creeps in, and that's what causes the contraction. Excellent. Okay, when the sodium comes in, it causes that contraction, and then the cell depolarizes and pushes the sodium back out. And when the sodium is back out, then it relaxes again. Okay, that's happening every beat of your heart, and every cell in your heart is doing this. Okay. All right. You're going to learn the magnesium is something that there's a waveform called torsades de points. It looks like VTAC, but it's like big VTAC, then real small, then big VTAC again, real small. and it's called torsades de pointe. That happens with a lack of magnesium. Magnesium. All right, don't forget the pathway of blood through the heart, and there's a circulation there. What are the layers? Make sure you know for the heart, the location, the layers, the chambers, the valves, and the type of vessels. Make sure you know all this about the heart. You know the location. It's retrosternal, right? Behind the sternum. It's medial in the mediastinum of the body, right? It hangs slightly to the what? Left, right? The layers are epicardium, myocardium, and I said that one already. Endocardium. Good.
Endocardium.
Good, good. The chambers of the heart are the four chambers are the what? Right ventricle, right atrium, left ventricle, left atrium. And the valves of the heart are what? The valves. Pulmonary valve,
Aortic valve.
aortic valve, two more, bicuspid and tricuspid. Good. Oh, that's all right. And then the types of vessels, of course, you have your coronary artery and your coronary vein. Don't forget about those two major vessels on the heart, right? Coronary artery carries the blood to the heart, right? The blood has to have heart, the heart has to have blood too, right? It has its own little circulation, right? And the used up blood that is the heart is using has to come back to the heart as well. Dumps back in through the coronary vein, right? Because veins take blood to the heart, arteries take blood away from the heart. So as the heart itself uses its own blood with the coronary artery, comes off of the aorta, and then it circulates on the body to supply the blood on the heart muscle. So it has oxygen and nutrients and platelets and all those things too. And as the metabolization and all the squeezing that's going on, it produces CO2, uses up the oxygen and produces carbon dioxide like the rest of the body. And that blood has to get dumped back into the right side of the heart to go back to the lungs to get oxygenated again, right? So the coronary artery and the coronary vein are the two major vessels on the heart. Okay, that's how the heart gets its blood and gets rid of its blood. All right, this is just the diagram of the heart here. Okay. Another nice little diagram letting you know the places. You can go back and look at the labeling of the heart. All right, the two types of vessels. Here go the artery here. This is the vein. Notice that the artery is bright red because it's fully what? Oxygenated. And then the vein is blue because it is deoxygenated. All right. And in between you have the capillaries. That's where they mix, right? That's where they go and they do their exchange. So gas exchange down at this level in the tissues is called what? Gas exchange at the tissue level is called what? There's a gas exchange in the alveoli, and there's a gas exchange at the tissue level. Internal what? Respiration, good. Internal respiration is the gas exchange in the tissues, right? And then at the lung level, it's called what? External respiration. External respiration is the gas exchange between the alveoli and the outside air. External, right? You breathe in the air, and the capillaries that are on the alveoli are gas exchanging between the capillary and the alveoli. That's external respiration. Well, the body has to do that too, right? Your feet need to gas exchange. Your legs need to gas exchange, right? Your back, your butt, everything has to have gas exchange. So at the tissue level, that's called internal respiration, right? Because respiration is simply gas exchange, okay? Ventilation is moving gas in and out. That's ventilation. But respiration is the actual gas exchange, okay? You can have ventilation and no respiration if your lungs are closed, right? You can move some air, but if there's a VQ problem, there is no respiration going on, right? No gas exchange, no magic, right? So you have to think about the difference between the two. There is a difference between ventilation and respiration. Ventilation is simply moving air. I don't care if it's in and out your lungs or in and out the room, right? Ventilating the room, right? It's just moving air. Respiration happens when gas exchange happens. And it either happens at the tissue level or it happens in the lungs. Internal respiration is gas exchange at the tissues, like she said. And the external respiration is gas exchange in the lungs. The primary function of the lungs is external respiration. Primary job of the lungs, external respiration. All right, this is another picture of some different veins and arteries as they pertain to the heart, right? You have your heart here, right? After the blood leaves the aorta, this is the aorta, right? Then it comes up the common carotids to go up the carotid artery to the brain. And then you have this aorta or this artery going down to the body. Now, look, right here becomes the brachial artery, right? The artery right here is your brachial artery, right? Then it comes on down to your radial artery down in here. Then you have an abdominal aorta, right? So sometimes this one can pop, can cause almost instant death, right? You feel a pop in you hear a pop in your stomach or something like that, and you start falling out. That's it. Your aorta in your stomach has popped, right? And then you have your iliac arteries, and then you have your femoral, right? Femoral artery. Now this femoral artery, this is down here, but you can feel it up in here, right? When I'm feeling for a pulse, we feel right in here, right? This iliac is that little one right there. I'm talking about the big one right here. This is the femoral artery right here, right in your groin. You can push right there and feel your pulse, right? In an emergency situation, that's where we feel it because of shock. If the body has lost a lot of blood, you're not going to feel a pulse down in the radial artery or the brachial. You're not going to feel it. The body will shunt all the blood to the midsection. So you'll feel it right here, and you can feel it in the carotids. All right? All right. Circulation and pulse. The pulse reflects the contraction of the ventricles. The left ventricle, right? That's the systole. That's what you feel when you feel your pulse. And this is how you know how to take a pulse. Make sure you remember the equipment and procedure for blood pressure, right? We just talked about the cardiac stimulus through the heart, right? Pathway to stimulation, the terminology, the EKG stuff, right? We talked about that. Make sure you touch up on that. Here is the picture of it. You got your SA node here, your AV node here, and then your left and right bundle branches, right? And then down to the Purkinje fibers. All right, terminology, we said systole is AKA contraction, AKA squeeze, AKA depolarization. Diastole is AKA relaxation, AKA repolarization. Okay, tachycardia, heart rate greater than 100, bradycardia less than 60. Okay, all right. We just talked about the charge and what happens. Ms. Tabor told us what happens in the cells that cause depolarization and repolarization. We talked about that. This is just a diagram of that, right? This is kind of showing you what's happening. You see the Na, which is sodium, going into the cell, right? Which the cell is nice and repolarized. And then when it comes in, it causes a problem. You have depolarization, right? And then you have, look at that, all kind of stuff going on here, right? You have all kind of stuff going on here. This is just an old picture of the cell membrane and the cytoplasm, and then another cell membrane showing you what's going on in and out the cell. Sodium was a positive charge, and potassium was the negative charge. All right, now the EKG. If nothing is happening, you have flat line, which is called what? What is this? Asystole. Remember, systole is contraction, right? A, it means no contraction. So no contraction, asystole. Nothing's happening at this point, right? Oh, okay. Asystole is when nothing is happening, flat line, okay? Now, look at the next one. It's showing you that the atria, the yellow, we're talking about the yellow. Atria are doing its thing, right? So they're getting ready to do its thing. So it's starting to come up, right? And then finally, when it contracts, that's the P wave. When the two atria contract, that's the P wave. All right? Then, after the atria contract and sent a signal down the left and right bundle branches, it's past the P wave, okay? On its way to do the ventricles. Now look, now the ventricles are contracting, and that's the what? QRS. The ventricles contracting with the QRS, right? It's just showing you how it's going down. This is a QRS. It's kind of breaking down the R and the QRS and all of that. But eventually, when it gets done, it's going to start to relax, right? The T wave will start to relax. And then this will be white, just like up here, okay? And start all over again. All right, this is just a picture showing you some different ways. We showed you how to do the counting the heart rate. Don't forget how you count the heart rate with the R's, right? The R waves. If it's a 6-second strip, I can count the R's and multiply by 10, right? But if I don't know there's a 6-second strip, I have to use the large boxes. Remember, between one large box, from this large box to this large box, is how many beats? One large box from here to here is how many beats?
1.
No, not one beat. If you're looking at an EKG and you see an R wave hit at this large box and then another R wave hit at the very next large box, that's 300. A heart rate of 300. If it's two large boxes in between, then it is 150. If there's 3 large boxes in between R's, it's 100. If it's 4 large boxes, it's 75. 5 large boxes is 60, and 6 large boxes will be 50. Okay. That's how you count a heart rate. See, that's showing you right here. From this R to this R, right? This is showing you that they have a heart rate of 60. This right here is a heart rate of 60. How do I know? Because how many large boxes in between? 1, 2, 3, 4, 5. Look, 5 small boxes is a heart rate of 60. If this next R wave was right here, then that would be a heart rate of what?
300.
Right there. 300. Next large box, 150 or 100, 75, 60, and if it was way over here, it would be 50. Okay? That's how you count the large boxes. We told you that extensively in the lecture. Okay? That's how you count the heart rate. All right, we have some things. Remember, you just make sure you know all your atrial waves and all your ventricular rhythms, right? Your atrial rhythms and your ventricular rhythms. You have your PACs, which is a premature atrial contraction. When you have a P wave come before another P wave, right? Just came too fast, right? That's a PAC. Don't forget what a flutter, atrial flutter, looks like the sawtooth, right? The sawtooth pattern is a flutter, looks like a knife, right? Looks like a knife. A fib is when the atrial just quivering. Look at that. The P waves are just quivering. That's atrial fibrillation. Those are all atrial rhythms, which are not deadly. Then we get into our ventricular rhythms, which some of these can be deadly. This is a PVC. Remember, the premature ventricular contraction is the PVC. Is when a QRS come out of nowhere. See that? It should be PQRST, 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 all of that. PQRST. Then look, QRS came out of nowhere before the P. See that? This QRS came before the P. That is a premature ventricular contraction. They are not deadly, but they can be dangerous if it's a lot of them together. Okay? Then VTAC. VTAC is one of your deadly rhythms. Look, you just was regular at first, and then all of a sudden, nothing but QRS. It's just bam, 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 right? That is ventricular tachycardia, which can be deadly. V-flutter. This is ventricular flutter. See how they're not as big, as wide as those other ones? That's the difference between VTAC, which is huge ones, and V-flutter. All right, that's V-flutter. Now, V-fib is coming up next, and that is deadly. All you have is just some fibrillation. Just the ventricles are just quivering, right? As they continue, if you don't fix that, they get thinner and thinner until they're flatline, okay? V-fib, you defib, okay? It's just, see these little ectopic foci. These little things here are called ectopic foci. We call them little demons, right? They just cause a contraction on their own. And so right here, the ventricular fibrillation just all over the ventricle. They just firing, just quivering, shaking. The ventricles are not shaking. So we said V field is physiologically the same as what? It might as well be what? V field is physiologically the same as what? Not A field. Asystole.
Asystole.
Good. Asystole. Go back and look at this stuff, y'all, and don't guess. Okay. Asystole, same thing. Cardiac standstill, right? Asystole is cardiac standstill. They ain't doing nothing. There's no contraction. And they saying that V field is just as might as well be that. All right, cardiovascular diseases. Make sure you go over your cardiovascular diseases. We talked about these few here, right? You also have some vascular diseases like the phlebitis and atherosclerosis and arteriosclerosis, all those kind of diseases. Make sure you go over those. That's cardiac A and P. All right, we'll take a break now. Let's take a 10-minute break. It is 15 after. Let's just say it's 15 after. Come back at 25 after. Come back at 9:25. We will continue on. We'll do a couple more sections, and then we're going to, which one of y'all have a makeup lab? Okay, we'll have a couple more sections, and then we'll do a makeup lab, and that will be it for today. Pause the recording. Okay, guys, we're back. Let's go ahead and continue on. All right, that was 210B. All right. Quick reminder, the shot nurse will be here on Tuesday for you. So you need to, if you need TB scan done and Hep B second, third, whatever your shots are, you need to be here on Tuesday to get them. Shot nurse will be here on Tuesday because they don't come often. You will be going to 220 next term, so they can't put you in any clinical sites until you have all of your shots. All right, if you don't have your vaccines and shots and all that kind of stuff, you can't go to any clinical sites. Now, as far as the med is concerned, I don't know if they're going to be any med stuff until they're asking for a full-time clinical instructor to be out there with their students, because a lot of students have burned us at the med. Okay, they go and then they don't go to clinical, they don't come, or they late, or they disappear in the hospital and then therapists don't know where they are, little stuff like that. And so they say, y'all for Concord, we're going to have an instructor with them. If not, they can't come. So you messed up with seeing traumas and all of that if the Concord not going to pay for a clinical instructor to do that. And so as of right now, that's what they're saying. They may change their mind as the need becomes more. But other schools have instructors. Okay, so that's just what it is. So, but no hospital is going to take you. And then the med is going to be one of the first hospitals in Tennessee to get the vaccine for COVID-19. I'm going to get mine, okay? Regardless, I pray up on mine. I'm not worried about none of that. It's not a live virus. It's a DNA sequencing vaccine. So it doesn't give any it doesn't give any dead virus or live virus. Like the flu shot you get now is dead flu virus. Okay. The vaccine for COVID is not a dead COVID virus. It's a DNA sequence that's going to keep you from, it makes you produce the spike that COVID sits on. Okay. Which when it sits on it, it can't do any effect. It becomes an antagonist. Okay. That spot that your DNA has made a new sequence on the cell that doesn't mess with your phenotype or how you gonna look or how your children gonna come out with 6 toes and none of that mess. But it makes a spike protein on the cell that the COVID-19 looks for and lands on. It lands on the same spike protein for everybody that's infected. And so it makes one for it. And so it latches on and doesn't cause any problems with you, or very, very mild symptoms, if any, until it's gone. Okay, that's what it's doing. And so, but the hospital does not require employees to have it, like the flu. You got to have a flu shot, but you don't have to have the COVID-19 vaccine. So if they decide to let you guys go, you won't have to get the COVID in order to go to the med. Okay.
So you say you still be covered with the vaccine, but it just won't.
Well, just like the flu vaccine, just like the flu, you can still catch the flu, but it's just very, very mild. You might not even know you caught it. Okay. The flu vaccine don't say that you just don't get the flu, but there's so many different strains of flus and different types. You may get a little bit of a flu. If you do get it, you may not even know you got it because it's so mild. Okay. But as long as the COVID-19 is mild, who cares, right? Who cares? Because if it's major, it can kill you. So yeah, so ain't no joke. All right, so let's go on. Yeah, go ahead.
You said the flu shot nurse, the flu shot nurse.
Tuesday.
Shot nurse, you explain what time?
I guess it's beer at 8, just like regular.
Okay.
It's beer at 8. Yeah. And I did also, guys, they told me that the next term for 210 will be at 1. I thought they were going to hold it on from, just keep on doing 8 to 1 like we've been doing, but it turns out it might be at 1. As of right now, the class will be 1 p.m. to 6 p.m. If you fail 210, and this is your first time failing 210, you'll be able to return at 1 next term. Okay? That's for 210. Yeah, I'm the only one for 210. Yeah, but 220 is 8 o'clock like any other time. Okay? 220, you'll still be 8 a.m. Now, if I have any students who have failed 210 before and you failed it again, then you're out of the program. Okay? All right, so that's just for the recording. So yeah, so don't be looking for 8 a.m. next term if you don't pass 210. If you don't pass 210, you'll be coming back to 210, but at 1 p.m., 1 to 6, Monday through Friday. Okay? All right. Pulmonary A&P. We'll run through pulmonary A&P rather quickly, and then we'll start doing some checkoffs. Remember, the pulmonary A&P had a lot of stuff, those segments, all that kind of stuff. You're going to have to know those segments when we start asking these questions. Hope you've been studying these oral questions and going back to your stuff. So if I ask you some oral questions, you shouldn't be like, oh no. You need to know because it's coming up. Oral exam is coming up. All right, slideshow. No, they're not going to switch. They give you a little love. All right. Don't forget the upper airway. We start off with the upper airway. The upper airway is what warms, humidifies, and filters the gas. Make sure you know the components of the upper airway. Your oral, nasal, and laryngeal pharynx is up in your upper airway, and it does the job of heating and moisturizing the gas. Upper airway has many parts and pieces, right? You had homework for these to be able to label this stuff to know what it is, okay? You may have a diagram on the test. You may not. It won't be all of this, but make sure you know your pulmonary A&P. Then we get into our lower airway. We get into our lower airway, and we talk about the larynx, right? We talk about the larynx. We have the epiglottis, thyroid, and cricoid cartilages, right? You got the epiglottis, protects the airway from food, right? It's inside. The thyroid cartilage, which is out here, protects the thyroid, right? The thyroid. The thyroid is also, thyroid cartilage is also known as the what? Adam's apple. Adam's apple. That Adam's apple you feel, that's the cricoid, the thyroid cartilage. Then we get down into the trachea, right? And then there's one complete ring of the trachea, and that's called the cricoid. The cricoid. That's the only complete ring of the trachea, right? The cricoid. It's right here. It goes all the way around. The rest of them are just little C-shaped clamps, like a staple, right? From here to here, as far as it goes. From here to here, from here to here, right? But the cricoid goes all the way around. All right, this is a picture of the tracheobronchial tree that was done by a computer-generated image. It's actual tracheobronchial tree, starting with the trachea, then your left and right main stem bronchus, or your left and right main stem bronchus, right? Then your segmental bronchi, right? Or your bronchi, then your segmental bronchi go into the perspective segments, right? Then you go into bronchioles, terminal bronchioles, then your respiratory bronchioles, which is the parenchyma of the lungs. Okay. All right, here it is right here. Trachea, left and right main stem bronchus. These are your bronchi right here. And then this is a segmental bronchi. Remember, the right upper lung has how many segments? 3. 1,
3.
2, 3. Right? And then the right, well, this one don't really show. Well, this is the middle lobe here, and this one would be down in the lower lobe. Okay? But those are your lobes. The left lung has upper lobe and lower lobe. Right? So you have your segmental bronchi that go off into all of the little segments of your upper lobe and your lower lobe. This is trying to mostly show you the layers of the tracheobronchial tree. Okay, this is down here in the parenchyma, right? The respiratory zone starts right here. This blue line from here down is the respiratory zone, also known as the parenchyma. That is where your alveoli and your respiratory bronchioles. These are your respiratory bronchioles. These right here, right? These long pieces here are your respiratory bronchioles. And your alveolar ducts and sacs come off of those. All right, alveolar cells, don't forget the type cells. We have type 1, type 2, and type 3. This picture here on the left is just kind of showing you how the blood is transfused in and out. The gas is transfused or exchanged in and out of the alveoli. Am I recording? Please tell me. Okay. All right. The deoxygenated blood is coming to the alveoli, deoxygenated in blue. CO2 leaves the capillary and goes into the alveoli, and then oxygen leaves the alveoli and goes into the capillary, mixes up, starts to become very, very what? Red, because O2 is going in, turning it red. Now it's bright oxygenated blood going back to the heart to be distributed to the body. Okay? Anybody not understand gas exchange? All right, this is another picture of the same thing right here. Another picture. And this is a cross section. If I was to slice one right down the middle and look down into it, this is a cross section, like this right here. If this is the alveoli and I slice and then I'm looking down into it. That picture there is me looking down into the alveoli. You got the capillary beside it, right? Because the capillaries lay on top. But if I cut the capillary and the alveoli, then I look down, I'm looking at the capillary as well as the alveoli, okay? You have type 1 cell, right? Is the outer rim of the alveoli. Type 1 cell is particularly for what? Gas exchange, allows for gas diffusion. So type 1 alveolar cell is this purple part. Mostly of most cell that makes up that cell is that type 1. Okay, that makes sense, right? Because we want gas to be able to exchange from all areas of the alveoli. So the type 1 cell, which lines the cell, is for gas exchange, allows oxygen and CO2 to pass through it. Okay. Type 2 cell is this one right here, which produces what? Surfactant. Produces surfactant. And then the type 3 cell right here is the macrophages, right? Which eat foreign material. Okay. What's inside the alveoli? What should be inside this alveoli? What should be inside the alveoli? Well, gas. Inside the alveoli should be nothing but gas. We want the alveoli to be full of gas, right? The surfactant is just a little layer. See, that's the surfactant in blue. It's just a little layer to make sure it can stretch and do what it needs to do. But inside the alveoli, it should be full of air. That's what we want, right? We want air inside the alveoli. Same thing here, just another picture of it. See, the blue is the surfactant layer. That's the surfactant through here, right? Then type 1 cell allows for the gas to go in and out the cell, right? And then inside is airspace. This should be all air in here. Right, then here goes your type 3 cell in here, alveolar macrophage, to eat foreign materials. All right, we said the main purpose of the lungs is external respiration. The main function of the lungs, external respiration. Here go the lungs here. Here go the right lung. It has 1, 2, 3 lobes. Left lung has 1, 2. But it also has a little lingular section, right? But lobes, right lung has 3 lobes, left lung has 2 lobes, right? But if you look at the right lung, the upper lobe has 3 segments, 1, 2, and 3 segments, right? Segments of the lung. All right, then we start talking about the pleura. We said we have one pleura that touches the actual thorax and one that touches the actual lung or organ. Right? The visceral pleura touches the actual skin of the organ. That is the lining of the actual organ. Parietal pleura was the one that touches the thorax. Don't forget that. In between the two, there's a space called the pleural cavity. In between those two pleura, the parietal and the visceral, there's a little space in here called the pleural cavity. Right? And inside that pleural cavity is an amount of fluid called serous fluid. And the serous fluid is there to prevent friction. Okay, that's the only reason it's there. Okay. Now, what is it when this serous fluid, say right in here, the serous fluid here for somehow leaks into the abdomen? What is that called? What is that called when that serous fluid starts leaking into the abdomen? And what does it cause? Not pleural effusion. That's when these two pleura stick together. They infuse together. What is it when the serous fluid leaks out into the abdomen? Ms. Rose, you with us?
Yes.
You remember what it is? No, not abdominal distension. Ascites. Ascites is when serous fluid starts to collect in the abdominal cavity, and that causes a restriction, right? So look right here. If I got fluid all in here, a whole bunch of fluid, can my diaphragm go down? See, my diaphragm can't go down because there's a bunch of fluid in my abdominal cavity. That's causing a restriction. Anytime the diaphragm cannot do what it was made to do, the lungs can't expand if the diaphragm can't go down, right? So that's why we say if you have pregnancy or you have a very large stomach or ascites or anything like that, abdominal tumor, if you had a large tumor right here, see, the diaphragm cannot contract or cannot flatten. That's a restriction. That's why ascites is a restrictive disease in the abdominal category. Okay? All right. The Hylum, that's this right here. This space right here where everything goes in and out of the lungs in a hole called the what? The Hylum, which is also known as the root. That's where everything goes in, right here. You got your pulmonary arteries and your pulmonary veins and your left and right main stem bronchus. All of it goes into the lungs at the Hylum. Okay? Bony thorax, just remember your ribs and stuff of the bony thorax, the parts of your sternum. The top part of your sternum is called the what? The top part of the sternum is called the what? You got the manubrium. What's the middle part called? No. Hello? Okay. The paper is not even showing it, though. That's the thing. Yeah, I'll call you back. All right. Okay. That whole thing is the sternum. The three
Is
parts
the
of
body?
the body. You got the manubrium. Oh, my battery running low. Manubrium, the body, and that little point down there is called the
Xiphoid.
xiphoid process. The xiphoid process, right there on the screen. The X word. The xiphoid process. The sternum is made up of three parts. The manubrium is the top part. The middle part is the body. And the bottom part is called the xiphoid process. That's the three parts of your sternum. All right. Now, there are some landmarks. Don't forget those landmarks of the lungs inside the body, because you can do behind the bone. Behind the bone, there are some certain things that we can imagine are there. You can't stick your finger through a bone, but if you could, that's what they're saying. The notch between the manubrium and the body of the sternum is called the angle of Lewis. This little notch right here between the manubrium and the body of the sternum is called the angle of Lewis. Behind the angle of Lewis, what should I be able to touch? If I can stick my finger through the angle of Lewis, the what?
Carina.
Carina. The carina. And the carina is what? There you go. Good. Where the left and right main stem bronchus bifurcate. That's the carina. Okay. Where the left and right main stem bifurcate is the carina. Right? So if I could stick my finger through that xiphoid, through this angle of Lewis, I could touch the carina. What they want you to know. What landmark is behind the angle of Lewis? You need to pick the carina. Okay? Definitely will be a test question. This is also kind of showing you intercostal spaces, right? You got your clavicle here, right? This is your first rib, second intercostal space. Intercostal space is the space in between the costals, which are the ribs, right? This is important because when we do our EKGs, we need to know where we are with our leads, right? The V1 and V2 go where? No.
Between the first three ribs.
It's the fourth intercostal space, left and right of the sternum, right? V1 goes fourth intercostal space to the right of the sternum. And then, to the left of the sternum, right? Patient's left. V2 goes fourth intercostal space to the right of the sternum, right? Right around nipple line almost. Little bit. So look, this is the second space, third space, fourth space. So right in here, right above the nipples is where your left V1 and V2 go. Fourth intercostal space. If this is the second intercostal space, third, fourth, right? And then the V4 goes fifth intercostal space, mid-clavicular. So this is the clavicle line. This is the mid-clavicle line. So if I come down to the fifth intercostal space, mid-clavicular is where V4 would go, right? And then V3 will go between V2 and V4, right? Then V6 is axillary, right? Fifth intercostal space, or it might be sixth. Mid-axillary, right? Which is under the armpit. And then V5 will go between V6 and V4. Don't forget how to put on your leads, because you may have to do that in 220. You might say, oh, we got to get an EKG. Go ahead and set them up for me. You need to know how to put them stickers on there. You need to know what you're doing. Now, you ain't going to have to be filling on the patient. You don't do that in the hospital, right? You just kind of know where they go and then make a little loop and be through with it, okay? They're not going, but if they ask you, where are you putting that, you need to be able to tell them. In the MBRC hospital, when you take the final or the board exam, you got to know where to tell the doctor, okay? Because you're going to have simulations as well. They're going to say, this scenario has happened. What do you want to do first? Oh, I want to do this first. And they say, doctor says, you missed that one, okay? Or doctor say, yes, I agree. Okay, what you want to do next? Oh, I want to do this next. Yes, I agree. And that will be everything you've learned in respiratory, not just 210, but everything from 210 to 250 is in that one scenario as a therapist. So that's why it's important to go back and look, study your old stuff. My YouTube page is always there. So when you get to 230, 240, and you look back at some 210 stuff, it's on the YouTube page. Every lecture I do is on my page. Every single one. Okay? All right. Mediastinum. Don't forget the mediastinum. That's just everything that's in the middle. There are some particular things in the notes that say that's all in the mediastinum. Remember, we had that question. Which one of these is not in the mediastinum? Stuff like that. So make sure you look at your notes and know what's all in the mediastinum. All right. Our goblet cells. We said goblet cells produce what? Mucus. Gobs and gobs of mucus, right? Those are one of the things that make the mucus. What else makes mucus? Huh? Submucosal glands. Submucosal glands. That's the glands at the bottom, right? Way down in here, called submucosal glands, also produce mucus. And as they produce it, they push it up across the top of the cells, which forms a blanket, right? Forms a blanket. Here it is right here. You have the blanket of mucus right here, laying on top of the cilia, right? And that mucus, if we look at it right here, it's a little closer, the mucus blanket is made up of two levels of mucus. What are the two levels or layers of mucus?
Sole layer and gel layer.
Sole layer and the gel layer. The sole layer and the gel layer. The sole layer is where the cilia go up into the sole layer, and the gel layer is responsible for what? Catching particles. And the cilia beat in one direction and push that whole little blanket right up the lungs, right? Just like this paper here. If this was the mucus blanket, the cilia just move the blanket across the cells, just like that. You see the cells and just see that mucus just moving, right? Up the hill, escalating. Mucociliary escalator. Mucus is just, you're like, well, how is that mucus moving? It's because of those little cilia that are beating and moving it up to the larger airway so you can cough it out, okay? And these glands down here, these are submucosal glands. See, gland, these submucosal glands, right, under the muscle, right? Under the muscle is the submucosal glands that produce also mucus. This is another nice little picture of it, showing the mucus blanket moving in one direction, being moved or propelled forward by the cilia. Propelled by the cilia, right? You have your blanket here, you have your gel layer and your sole layer, and your goblet cells right here, right? Just showing you how it works. Excuse me. All right, then the diaphragm. We talked about the diaphragm. Make sure you know, it said the diaphragm can move up to 6 to 10 centimeters during labor breathing, but make sure you understand or remember how much does it move during normal breathing, okay? How much it moves during normal breathing. Make sure you know that, okay? Now, when the labor breathing is not enough and the diaphragm is not enough, we start going into our accessory muscles. All right, so make sure you know which one of your accessory muscles does what. If I said which one of the accessory which one of the accessory muscles directly lift the manubrium? If the question said which one of your accessory muscles directly lift the manubrium?
Is it the pectoralis?
Oh, look at the picture. Where is the manubrium? And which one of those muscles are directly connected to the manubrium? Sternocleidomastoid. This is the manubrium, guys. The manubrium is the top part of the sternum. This is the manubrium. This is the body of the sternum. And this is the xiphoid process. The manubrium, the only one connected to the manubrium is this muscle right here, which is the sternocleidomastoid. The question may say elevates the sternum. The question might say elevates the manubrium. That's how it assesses. If the diaphragm ain't working or not doing enough, then the sternocleidomastoid will start lifting up that sternum. It's a muscle that starts pulling it up, trying to open that chest up so that the lungs can fill up more in the event of labor situation, okay? And then which muscles will lift up the upper ribs? Which muscles help lift up the upper ribs? Scalene, right here. Scalene elevate the upper ribs. So this rib and this rib, you know, right through here, it's going to help pull them bad boys up some. The whole purpose is to make the AP diameter larger, anterior to posterior diameter of the thorax bigger, okay? Because the lungs are filling up, but it ain't enough. So the body will try to make yourself bigger in order to facilitate a bigger breath, okay? So those are your accessory muscles. Now, don't forget about your intercostal muscles and what they do. Which one of your intercostal muscles help with inspiration? Which one of your intercostal muscles help with inspiration? Which one of the intercostal? You have two types of intercostal muscles, interior and exterior.
Interior oblique.
No, not the obliques, baby. That's the abdominals. We're talking about intercostals right now. I switched the page on purpose because it was written down. I want to see if you know. Intercostal muscles. You have two types. Internal and external intercostal muscles. You have two types. Which one of those help with inspiration? Which one of the intercostal muscles help with inspiration? One or the other helps with that. Exterior? Exterior, good. The exterior intercostal muscles help with inspiration, and the interior intercostals help with expiration. Okay? That's how that works. Showing you right here. External intercostals, right, elevate the ribs, right? Externals help with inspiration because they elevate the ribs. They make the ribs go up and out. And the internal intercostal muscles, right here, internal intercostals pull the ribs down. Internal intercostals pull the ribs down, so they help with expiration, right? You get bigger to inspire, and then you come down. When you come down, those are your internal intercostals are pulling the ribs back down, okay? Don't forget that. They're opposite, so don't forget that. And then, of course, for exhalation, then, Ms. Rose, we get into the abdominal muscles. Okay, so exhalation, we in abdominal muscles. For forced exhalation, it's just the abdominal muscles. But, of course, exhalation period, you're going to have some internal intercostals, because that's what we said. Internal intercostals help pull the ribs back together. Now, if I'm trying to blow out some candles, I'm not worried about my intercostals. I'm now dealing with my, which ones would you be using when you blow out some candles? What do you feel if you were sitting here blowing out some candles right now? What would you feel be using right now? What would you be using?
Abdominal muscle.
Right? Your stomach to blow them candles out, right? It's your abdominal muscle. Now, you don't have to remember the rectus, external, internal, all that stuff of abdominal. Just know that the abdominal muscles are used for forced exhalation. All right. Then we had types of breathing. Don't forget your breathing patterns. Things you might see will be Cheyne-Stokes, which is changing rates of depth and rate, right? So it might be, look how it is. It's small, then big, and big, 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 and stop. Small, small, big, 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 stop. It's going to keep doing that. If they have Cheyne-Stokes, it's going to do that. These right here with periods of apnea. Flat line is apnea. That's Cheyne-Stokes. And then Kussmaul's is fast and deep, and it doesn't stop. Just constant, and they don't stop. That's Kussmaul's breathing. Come from metabolic acidosis, right? Metabolic acidosis so bad that it's trying to blow off CO2. That's the only way the body knows how to get rid of CO2 is exhalation. Taking deep breaths, right? So that's what it's trying to do. Of course, there's your normal there. You don't have to know obstructive. Bradypnea is a slow respiratory rate. What rate is it when it's slow? Less than what? Respiratory rate, not heart rate. Any respiratory rate less than what, Ms. Tabor?
12.
12. Respiratory rate less than 12 is bradypnea. And a respiratory rate greater than what is tachypnea? 20. 12 to 20 is normal. So tachypnea or bradypnea. Tachypnea or bradypnea. Somebody is tachypnic, they're breathing greater than 20 times a minute. Okay? If they're bradypnea, then they're breathing less than 12. All right? All right, then we had our, make sure you go back and look at your respiratory centers, understanding what the pons do and what the medullary response center does. The pons has its pneumotaxic center and the apneustic center. That's in the pons, right? In the pons, we have the pneumotaxic center and the apneustic center. Make sure you go back and look at that in your notes. And don't worry about that pre-Baldinger complex. But you do need to know the medullary respiratory center had the dorsal and the ventral group. What do they do? Right? How do they help? Right? How do they help? What is it called when it's the stretch receptor? What is that stretch receptor called in the lungs that when they start to stretch?
Bearings,
Herringbird. The Herringbird reflex. Good. The Herringbird reflex happens when the lungs start to stretch so much that you're like, hey, the lungs are like, hey, that's enough, right? Those stretch receptors activate and tell the body, hey, that's enough. And they send signals to the pneumotaxic center to say, hey, you need to stop. Okay? So make sure you go back in your notes and understand that, study that part. Stethoscope. All right, breath sounds. Breath sounds. We talked about what vesicular means. What does vesicular mean? What's vesicular mean? Vesicular breath sounds. What does that mean? So write that down. You need to know what vesicular. You got to know what vesicular means and adventitious. So write down vesicular. To make sure you go back and be able to understand what it means. What does vesicular mean? Because you might see the word vesicular instead of the other terminology that's easy to remember. You might see vesicular. It might say the patient, that might be part of your scenario. Patient came into the hospital, sat in 100%, vesicular breath sound. You got to know what that means because that lets me know what do I do next. Do I need to get an x-ray because of vesicular breath sound? Or do I need to leave them alone? Do I need to give them a breathing treatment, right? I need to know what vesicular means, okay? So write vesicular down and write adventitious. Adventitious, what is that? They're the opposite of each other. It's either vesicular or adventitious. Vesicular or adventitious. Got to know that if you're a respiratory therapist. You got to know what that means, okay? And it's been like, oh, okay, it's not hard, it's much, but the terminology, you got to know it. All right? Huh? That's what you're going to tell me. I need you to know what vesicular is and what the adventitious is. You need to be able to know that. All right, your segments. Don't forget about those bad boys. All those segments, Rose, now was it Miss Rose or was it Miss Thomas? No, Miss Thomas knew the electrolytes real good last time. And then Miss Rose, I think, knew all of the segments real good. All right, but everybody needs to know both of them. All right, this is my right upper lobe. Has 3 segments. See, this is the right upper lobe. Has a posterior, anterior, apical. Then my right middle lobe has a lateral and a medial. Remember when I showed you, asked me what the sagittal plane and all that stuff is? Those are showing you sections. Medial is the one closest to the middle, right? So this is the medial section, and this will be the lateral, okay? This is medial. This is lateral, because medial is closer inside, right? Okay, then the right lower lobe has superior, right? Which is, you can see it in the back better. Then you have the anterior basal, lateral basal. Superior, anterior basal, lateral basal in your right lower lobe. Okay. Then you have your same thing over here on the left. Left upper lobe has apical posterior, anterior, right? Then you have, of course, they put these together with the lingula. You have the superior lingula and the inferior lingula. All that's considered the left upper lobe. In the left lower lobe, of course, you have superior, just like you have on the right side. Then you have lateral basal, anterior medial, or anterior medial basal. I don't know what that is. Anterior and medial basal, I guess. You have to know. Go back and make sure you know that. I don't want to tell you the wrong thing, but these are your segments of your lungs. So if I said, how do I drain the anterior segment of my left upper lobe? You got to know I want this up in the air. I got to be able, just simple as that. I need to get this right here up in the air, right? Or if I said drain the medial segment of the right upper lobe, you got to know, oh, I need to get this up in the air, right? Got to get this up in the air. So how would I turn him, right? He'd be on his right side. Now, not on his right side, he'd be on his what? Left side to get that up in the air, right? You got to know that. You got to know these segments. They're not going anywhere on the oral, not going anywhere on the final or the board exam. So you might as well memorize. If you're not taking time to memorize this stuff and really taking it like that, it's gonna show up. It's gonna show up. All right. Where does gas exchange begin? Respiratory
Tissue level?
No. What I'm saying, where does gas exchange begin in the lungs? I should have said in the lungs. The respiratory bronchioles. That's where it starts, right? They get off the bus at the terminal, right? Terminal bronchioles is where they get off the bus, the conducting zone. The terminal bronchioles ends conduction, right? When I get off of the train was conducting me to the station, right? The conductor was the one who was driving the train, right? And so, or talking about it. So everything from the mouth all the way down to the terminal bronchioles is simply conducting zones, right? And all of the gas in that conducting zone is considered to be what type of gas? Dead space, because there's nothing happening, right? No magic is happening. After the conducting zone, we get off of the bus into the land of the parenchyma, and that's where the respiratory bronchioles start. The respiratory bronchioles then house the alveoli, okay? Gas exchange starts with the respiratory bronchioles. Now, how do the respiratory bronchioles communicate with the alveoli? Through what? The respiratory bronchiole communicates with the alveoli through the what? Not the pores of Kahn, it's before that. Canals of Lambert. The respiratory bronchiole communicates with the alveoli through the canal of Lambert. The alveoli communicate with each other through the pores of Kahn. That communication is called what? There's a term for that communication. Definitely was on the test and it's going to be on this test. That communication is called something. Where they can share gas between the pores of Kahn, that's called collateral ventilation. Collateral ventilation. Collateral ventilation. All right. That is pulmonary A&P. All right, so today we covered review, preparing so far, because I got some cards too. But in review so far, we have gone over RT210A, RT210B, and RT210C review. All right. Terminology, then we did cardiac A&P, and we did pulmonary A&P. All right. As at this point, we'll take a little break, and then we're going to go over and knock out a couple of these little check-offs that people needed to check off. And then on tomorrow, which is what, Wednesday? Okay, tomorrow we will continue review with RT210D, which is mechanical, pulmonary mechanics. Pulmonary mechanics, that's going to be the spirogram, right? IRV, SRVs, and then tidal volume and minute ventilation, alveolar minute ventilation. We're getting into the alveolar air equation. I'm going to be having some of those problems to work out for you. You're going to have to work out some problems for me on that, okay? For homework tonight will be a spreadsheet. I'm going to put a spreadsheet in there that's got the ABGs. I don't know if I sent it to you yet or not. I thought I emailed it to everybody.
I didn't get it. I was looking for it. I was looking for it this weekend.
Well, that's what's going to be for the homework. You're just going to turn it in for homework. Number one, you write what it is. Whatever, with whatever. Write it down. All right? And we'll do that tomorrow, okay? That'll be for homework tonight. It's going to be the ABGs. It's going to be a spreadsheet I'm going to put in there. It's just like 10 ABGs. I want you to interpret those ABGs. I believe they're all on room air, okay? That will be the homework for the night. Tomorrow, you come in, be prepared to check off, I mean, not check off, but review. Starting with 210D and definitely E, right, with your ABGs after that. And then depending on how much review I can get, I don't know how many, if I get to the next one or not, but we're just going to be reviewing every day until it's time. Now, in between time, don't be waiting on me for review. You need to be going back and looking at, we got all of the lectures are on there. The PowerPoints are all open for you to look at. It's totally up to you to take that extra step to be looking at this stuff. You need to not go to work, whatever you need to do, because this is crunch time, okay? This is crunch time. If you get a 74.5, they don't round. You have a 74. Okay, I'm telling you that now before you're like, well, that's a 74. They ought to round. They ought to, but they don't, okay? MLGW ought to give you free electricity, but they don't, all right? That's just the bottom line. That's the policy. So if you get a 74.5, 7.6, you can't do nothing about it, but you should have got a 75, okay? That's nobody's fault but our own if we don't get a 75, okay? That's on you, all right? Everything is open for you to look at. Go look at them tonight. Work on those ABGs tonight. Study, study, study. Look at Dr. McNally's video on YouTube about the segments if you need to look at that again, right? All those things are in the module. You just go to the module and start studying every day, preparing for the final and the oral, because no telling where we will be in review when they come get you for your oral. You can't say, well, we didn't get to go through all of them yet. It's not supposed to. We're preparing every day. We're preparing every day, and you should be preparing every night, okay? All right, have a good day. I'll see you guys tomorrow at 8 o'clock for the next review. Homework will be put in the system with the lecture at a little later today. Have a good day.